So I'm going to talk about the indications and the technique, showing the technique of it. Now, this is a very common scenario when you get such type of cases, and more so if you have, listen all these talks. There is a large disc prolapse with deficit. There is a presence of facetal arthropathy, and if you see properly, there is a mild retrolysis in that area also. You have heard all these procedures which have been discussed: microdiscectomy, endoscopy, decompression of different variety. And as Dr. Samir mentioned rightly, the standing also, it was an endospine. It started with the word endospine. So practically all these are the different ways to approach a pathology, and you have to tackle the pathology which is causing the symptom to the patient. Now I'm going to add fusion in all this. What are the situations where you are going to use this? So which procedure is to be done? It should be always case specific. Okay, what is the demand of your case? That is very important. Literature is sometimes confusing and biased also. Now this is so when one should consider fusion when there is a significant axial back pain at index side. Now, if you are planning to fuse and you tell that back pain is the reason for that, you must understand that pain in back is multifactorial. And as a treating surgeon, you should know what is there in that case. Because sometimes, because of this multifactorial reasons, you might be swayed away from the real pathology. This is extremely important. You will find in your cases there may be genuine clinical radiological pathology, but sometimes there is a psychological factor, the patient's belief and disbelief, and his personality. This plays a lot of role if the patient comes with the just back pain. And there are other issues also, like medical legal issue, and we should be aware about that. So first meeting, if the patient is not having significant neurological deficit and he is complaining of pain, and of course he is having symptoms of that, radicular symptoms, don't jump for fusion. You first analyze your case very properly. This is extremely important. So proper evaluation of the patient is extremely important. Okay. Try to know the exact cause of patient symptom. Then it will be easier for you to choose one where I am supposed to do this fusion part. This is extremely important. And you ask yourself, what is the aim of your surgical intervention? So if there is a neural compression, definitely you are going to treat with the neural decompression. If patient has instability and axial back pain, then internal fixation and fusion is required. So instability is the main indication for surgical fusion, remember. So this is the main reason for that, and that becomes the indication. Now, whatever procedure you do, procedure should address the purpose of surgery. It should not add to collateral damage. So even if you are doing open surgery, you have to restrict, from here to here, I have to expose that part and do my job. So need not unnecessarily open proximally or distally. The indication of primary fusion during lumbar discectomy. So what are the absolute indications? Decompression you want to do with grade 2 or greater spondylolisthesis. If you already grade 2 or more than that, you have to fuse that segment. After repeated discectomy, more than 2, already twice the discectomy has been done, and third time patient has come to you, it is better to fuse that area. Presence of demonstrable instability. So when you do the dynamic film, you find there is a translation movement more than 3 millimeter and angular movement more than 10 degree. Established mechanical back pain. Clinically also sometimes patient, whenever he gets up, they catch and then gently tries to stabilize his trunk and then he tries to stand like this. It means clinically also you can diagnose that this patient has mechanical instability. There is a mechanical back pain. Okay. And after doing bilateral fascectomy, now suppose you are doing some case where there is a significant compression and you had to take out both the side facet, then you have to fuse that segment. It is essential. Now there are controversial indications, and these are decompression with grade 1 spondylolisthesis. Suggested mechanical back pain. You are not pretty sure, but patient is constantly telling that he has mechanical back pain. In that case, it becomes a controversial indication, and after unilateral fascectomy. Now, earlier when we were MS, we were taught that if there is a unilateral, damage of the facet, you need not fuse. because one side is intact. Unless you have taken out both the sides. Even 50% bilateral you need not fuse. So that was the standard teaching. But now this has become in the gamut of this controversial indication. Okay. So that we should be aware about. And this is a good paper where everything has been described very nicely. Lumbar as well as cervical. So apart from providing immediate stability, fixation improves the fusion rate. So if we are fusing, it is better to do the instrumented fusion. Non-union rate is almost negligible. Okay. Now this patient presented to me. He was a 40 years guy, a manual worker. He has low back pain off and on since 4 to 5 years. Then he started having significant radicular symptom. He started developing neurological deficits, hyposthesia, and this was his X-ray. You can see there is a loss of lordosis because of the acute episode of muscle spasm, and there are degenerative changes you can notice at that reference level. It is L4-5. There are osteophytic thing, and there is changes. You can see this MRI changes where there is a end plate changes. So these are the cases. If just discectomy, it might cause problem. And here just total instability. There was a mild retrolysis in there, and that used to be mobile. He used to have a catch-like thing. So it was a mechanical back pain definitely. There was a significant neural compression. You can see total cutoff in the MRI that. So the plan was neural decompression, that is discectomy, and instrumented posterior lumbar interbody fusion. Now, interbody fusion, which may be of different type, you can do PLIF, you can do TLIF or ALIF, is better than intertransverse fusion because the fusion bed is large and osteogenic. It lies in the weight bearing zone. So fusion rate is high if you do in the interbody area. So I will just first describe this steps, safe and desired step of discectomy and posterior lumbar interbody fusion. Always take these care when you are positioning the patient, and have a marker check to confirm the level and have targeted length of exposure. So what is the advantage of that? You know from where to where I have to make an incision and open that. You unnecessarily, you need not open extensively. Okay. Reconfirm the level after deeper dissection, because that level should be your level. You should not miss the level. This is extremely important, and wrong level surgery are known. One can choose first pedicular screw fixation and then perform neural decompression and fusion, or vice versa. So many people, they do first pedicular fixation and then they will do compression. You can do vice versa. Both are equal. Only when you have already done the laminectomy, your cord is exposed, your neural sac is exposed. So protect that, because there should not be any accidental injury to the neural sac. That is important. So since we plan in this PLIF and interlaminar decompression, expose parts to parts, never excise the parts because it can lead to lysis, then do the discectomy. Thorough discectomy is done, and do fixation and fusion. Now there is just video, and so the patient is positioned. This was the on table. Expose that area which is required, and then you start opening. Okay. Try to do the subperiosteal dissection so that there is no bleeding. So don't go in the plane of muscle. Try to expose subperiosteally. Use corpse and use this roller pieces and try to retract it. Do the same thing on the opposite side. The respect of soft tissue is extremely important. Okay. If rough handling can lead to problem later on. Okay. The chances of infection becomes high. So all these things has to be taken care of. So usually when you are stripping these muscles, you go from distal to proximal like this, because that is the orientation of spinous process and lamina. Now, and when you try to do the decompression in the canal, go from proximal to distal because of the orientation of the nerve root. So these are the safe way of going. So both the side it has been exposed. Again, I call reconfirm the level. And now the deeper. Now see here, this corpse is actually walking on the facet joint. Here, try to preserve the facet which is proximally and distally. At that site, Where you are intending to fuse, you can fuse. Otherwise, proximal and distal facets should not be touched. That is important. Okay. Even when you are passing a screw, it should not, while doing that, you should not unnecessarily dissect the proximal facet. So here the interlaminar decompression has been done. Even the wash, you can see from parts to parts, and now the deeper decompression is being done. So interlaminar area is clear now. Small size forward, Harrison Ranger, and protect it and see that everything is free now. This is moving nicely without any comment. So you can palpate and see that yes, it is free. There is no compression as such posteriorly. And then you walk laterally, try to decompress that area, use petty and dissect there. You can see this bulge disc there. So a vertical incision is made there, anechotomy. And then use probe or your curved dura and try to just make it loose and then it will come easily. So single piece has come. Now again, don't leave it. There are still pieces there. You can judge with the MRI. Such a large piece had come outside. So that has to be taken out thoroughly. Don't leave any loose pieces. And since we are planning to fuse it, have a good curate and to curate the whole space nicely. Take out all the cartilage. Don't take out the subchondral bone. This is important. So this has come out. And again, move your pen field. If anything is remaining, take it out. Give a wash. And now here, this has been just protected. And now do the fixation part. That is, you can do the pedicular screw fixation and then do the later preparation. Now here the puka is being inserted in the interbody area and this itself clears the cartilage and whatever the remnant part of the annulus is there. So rotate it, protect the dura and take out all these material, loose material from there. Sometimes there are large osteophyte in the sides and that also it dents on the nerve root. So it is better to excise those osteophyte which is indenting on the nerve root. So clear that. The whole area from one side to another side can be cleared even if you are just approaching from the one side. You can do bilateral, but it is not required actually. Most of the time you can do from one side and you clear the whole space nicely because if your surface area is absolutely clean, it becomes an osteogenic and it adds to the fusion rate. So use the curved disc forceps, straight disc forceps and clear the whole space. And once you start your using your curate, you get a feeling, a sandy feeling, and it's a rubbing against the surfaces, and you get an idea. Okay, now all the soft tissues are cleared, and I'm getting the bony feeling. And try to hook out any piece which is remaining opposite side, and clear the whole space. Now, most of the time, single level, you get sufficient graft. If you are doing multiple level or a larger thing, then you require extra graft. Otherwise, that graft is sufficient. And now, first, try to put the bony chips, healthy bony chips inside, pack from one side to another side, and this lies anterior part. And copious amount of graft which is available there, you should put. Now here, the fusion is the aim, so you should not just throw one or two pieces. You have to do the meticulous fusion. This is extremely important. And now this cage is being inserted. You can see the sac has been protected nicely. And then you just punch it. Now here you can shift cage from one side to another side by using thin puka or osteotape. So this was the post of X-ray. So I'll conclude. The primary fusion should be considered in indicated cases of disc prolapse. The targeted area should be handled cautiously without causing inadvertent proximal or distal tissue injury. Thorough neural decompression, sound fixation, and meticulous fusion usually gives a long lasting, fruitful outcome. I thank you very much for your kind attention.